Okay. So, someone writing in the chat. Okay, perfect. Okay, so let's begin. I'll just go to the first folder, ECG. Many people call it differently. Some of them call it electrocardiogram, electrocardiograph, EKG, ECG, whatsoever you call it. ECG is practically created by a device, which normally does electrocardiographies. It is all about recording the electric activity of the heart, but I will explain everything to you immediately. Since I don't know whether I'm talking to only health professionals or to nurses or to doctors or whatsoever, I would like to go through the basics and then proceed to my next ECG examples. All of the ECGs you're going to see today are from my patients from last week. And I will be excited to know what kind of knowledge you bring with you about the printouts which I'm going to show. I have realized that there is definitely a deficiency in ECG knowledge in most of our African countries. I have come from Dokis Advice. This is the NGO which I founded, and we have been donating ECGs to various hospitals, and we have been trying to train people on how to use the devices, but I've realized that the basics are missing, so it doesn't make any sense to go to intensive courses without going through the basics first. Otherwise, people will just be looking at me and wondering what is he saying. So the most important thing for us is now just to be careful to understand. I will always say what is important and what's not important. Okay, my name is Daniel Ogutu. I'm an internal medical doctor. Today we're doing the first ECG course for this year. The next one is going to be on the 22nd of March. Note it for yourself. At the same time, you receive the links just as you received it today. If you may have interesting ECGs or printouts, and you want to talk about it, discuss about it because it's unclear of what you're seeing, I invite you to send me a WhatsApp picture on that number seen here. If you want these folders at the end of the session, just send me a message so that I know who wants the folders. I can send it to you via email, or also you can send me an email through our website. Next year, we will begin an intensive course with certificates which will be issued after the exams from Dokis Advice. For those who are not following us yet on Facebook, Instagram, Twitter, this will be the time to do it, and we will proceed. ECG, definition is clear, the process of recording the heart's electrical activity. Well, the first ECG was done in 1872 by Alexander Muirhead. He's the one who had patients who had fever, and he attached on the wrists of the patients a device and tried to record the heartbeat of those patients. So today we are looking at around over 120 years later. We have ECG devices. At that time, they were big like an MRI. And today we even have small devices. We even have watches which can record an ECG. So why should I run an ECG? The first and most important thing is ECG is cheap. It is quick. And if done well and even diagnosed well, it is very life-saving. There is no internal medical doctor which can work without an ECG. It's like one of the devices which you need for everything we do. In Kenya, I have seen that it is not common that all of the hospitals have an ECG, but I would like to urge, if there are directors or CEOs watching here, it is very important that every emergency unit should possess an ECG device to be able to detect such emergencies earlier. I will explain to you quickly why it is important. When you come back to Europe, every hospital, every ward, and every small clinic or even dispensary has an ECG device in their own office. So there is no way you can say you had seen a doctor and you didn't get an ECG done. When should I run an ECG? Now, the question is, you want to do an ECG, which patients do you choose to do an ECG for? Well, every patient who has a chest pain, every patient who comes, whether it's left or right or under the belly, wherever it is, wherever the chest pain occurs, all of these patients require an ECG within 10 minutes according to international guidelines. The reason is time is hard. Other patients who need an ECG immediately are patients who have dyspnea, the people who are coming short of breath, who cannot breathe or having breathing problems, they also need an ECG. Stroke patients also need an ECG. I will explain to you why. Chest patients, that is common because of heart attacks or arrhythmias, but stroke patients, since most of the strokes which we detect are embolic strokes, it is important for us to detect an arrhythmia, especially an atrial fibrillation, in order to be able to know whether that is a cause of the stroke, and even to give these patients the medications they need in order to avoid that they get another stroke. Another pack of patients who need ECGs are psychiatric patients, patients under antidepressants, SSRIs. All of these patients need an ECG because of the QT time. I will show you in a short while what a QT time means. When it gets too long, there can be arrhythmias, which may even lead to death if not seen early enough. So patients who have a number of QT, when the QT time is too long, it is important for us to know it early enough in order to remove the medication or give the patient another medication. Other patients are patients who come and say, oh, I have heart racing or heart pounding. I feel that my heart is pounding too fast. If it's too fast, we're talking about a pulse which is above 100, or a pulse which is lower than 45 when they come and they're dizzy, and maybe they even fell down, or they didn't know, they had a blackout, and all of a sudden they woke up and don't remember what happened. These patients require an ECG because I will show you later why, because there are so many diagnoses which can do with an ECG. So who said doing ECG is unnecessary? Whoever said this, I will show you why it is important for us to have ECGs in all our emergency sectors, because of the things we can see on an ECG, which many people don't know about. And today I'm going to go through them. I'll just show you the list. For example, rhythm disturbances. We will go through the details. We will do this in our intensive course during the year and go through each and every disease, atrial fibrillation, whatever you call it. You have all of the sicknesses here, but this is not all. We still have heart blocks. We have conduction problems, aberrations, AV nodes, right bundle, left bundle, QT syndromes by psychiatric patients. So all of this stuff, we can detect them in an ECG if we know how to use it and how to read it. We are not finished yet. You see, we have a number of diseases which can be life-threatening if we do not know how to read an ECG. Electrolytes disturbances, intoxication, talk about potassium, talk about calcium, ischemia, heart attacks, heart frequency changes, whatever you talk about, we can detect it in an ECG. So how does this work? We always have a 12-lead ECG, or we require a 12-lead ECG with 4 columns and 3 rows. As you see it on the picture, we have the chest leads V1 to V6, and then you also have the limb leads and the augmented limb leads. You practically don't need to know anything else than 1, 2, 3, AVR, AVL, AVF, V1 to V6. If you are the one going to do the ECG by yourself because you don't have a radiographer doing it, you'll have to know how to put in the ECG at place, and know where AVF, AVL, the augmented limb leads go to, and where the limb leads go to. I've created a picture here. The 12 lead is made of the Einthoven's triangle. I don't know if you've heard about it. I'm just going fast through it because it is important to know, but it is not essential for this course. You have, as you can see in the pictures, 1, 2, 3, AVF, AVL, AVR, and you see through the red lines where the electrical activity is going to be moved from the left hand to the right hand from the left hand to the left foot, from the right hand to the left foot, and so on and so forth. So this is how practically a 12-lead ECG is created now through these leads which we have. If you have any questions, just put them on the chat, and later on we'll look at them. Okay, so now I ask you to be attentive. You need to know what a PQRST wave is in order to be able to read an ECG. You need to know how they look like. You need to know what is normal in order to identify that an ECG is abnormal. The first thing and the most important thing for a nurse or for someone who will not be able to treat whatever we see on the ECG, it is important to know what is normal, what is not normal. I am showing you a normal ECG. This is how it looks like. You see, when you can see my arrow, you see that we have a baseline. The baseline is a straight line, which is very important, especially when we talk about heart attacks and we talk about reading ST elevations, which I will show you later on. So the baseline is very important. It's important that on the baseline, all of these 4 lines are always on the same baseline. If you see an ECG where you think the baseline is not clear, take a ruler, take a piece of paper, and hold the lines together and see whether they are all on one angle. So when it comes to the P wave is the atrial electrical activity of the heart. The heart has 4 chambers. You have the upper chambers and the lower chambers. So from P to Q, you have the activity of the upper chamber. We have the P wave, which goes upwards, and then you have the PR segment, which goes straight and meets the Q segment or the Q wave, which is a negative amplitude wave. And then the Q wave meets the R wave and the S wave. Beginning from the QRS, you have the activity of the lower heart chambers. Very important to know that. I will show you later on why this is important. After you leave the S wave and the heart is retracting, you will have the ST segment, the repolarization segment, where another T wave will be built. And you have between Q and T, the QT interval, which will be very important later on. So what you need to know is the P and the R interval, the Q and the T interval. These intervals you need to know, and you need to look at the T wave and the P wave and the R wave, which are always positive amplitudes. Okay, and then you have the Q and the S waves, which are always negative amplitudes when you look at a normal ECG. Okay, of course, you will see differences according to how the heart is pulsing from the V1 to the V6, but this is a special course. It is just about knowing the basics. So this is how it looks when it's normal. We have the QRS complex, you have the P wave, you have the T wave. From P to Q, or the PR interval, you have the activity of the upper chamber. From Q to T, you have the activity of the lower chamber. And everything starts afresh after that. So now this is how it is illustrated for you to look at it, and we will go through the heart anatomy for you to understand what is going on. You can see there's another U wave, which is represented on this picture. This is for a special course. I will talk about it later. There's also a U wave which can appear, but be careful that you do not think the U wave is the P wave when you talk about AV nodes or other kind of ECG rhythmic failures. Okay, so I have just explained the upper chamber, the lower chambers. We have the right atrium, the left atrium, right ventricle, left ventricle. You have the sinus node. Electrical activity is passed through the AV node, the atrioventricular node. Every time I say an AV node, I mean the atrioventricular node. And then you have the electrical activity passed through the His bundle, and then through the right bundle or the left bundle branch. Yeah. You can see in the other picture how it looks like, definitely, and now electrical activity of the work of the heart is passed on. Just take 2 seconds to look at the pictures in order to understand it, because at the end of this course, I will expect you to be able to tell me whether the electrical activity takes place at the upper chamber, at the lower chamber, or at the AV node. Okay. At this moment, I want to explain to you that most of the heart attacks, most of the disturbances you have through nodes which are built at the heart attacks, they come from the left ventricle. Yeah. So you may see that most of the muscles of the heart are represented on the lower chambers of the heart. And these are the parts of the heart which lose contraction when you have a heart attack. So I will ask you later on, where will you see a heart attack on an ECG? Will it be the PR wave, or will it be the QT time? Yeah, like I showed you before. Yeah. Okay, we move now. I'll show you a picture of what I mean of. You have the sinus node, just as I explained. Electrical impulsion will be removed from the upper chamber. At the sinus node, you have the P interval. On the lower page, this blue line is what shows you have the baseline, and now it is rising to a P wave. And electrical activity passes the upper chambers, and the P wave is rising. And the P wave is completely built, as you can see here, when the whole of the upper chambers have been electrified, and now we come to the AV node, the atrioventricular node. This is a red point over here. We proceed, the ECG, the QRS complex. This is how it takes place. You have the P wave, PT line. You have the Q wave, which is built when you reach the His bundle, and then the R wave is built up and goes down. And here you see that most of the lower chambers and the muscles of the heart are being electrified. Now you see that the heart is contracting, and you have the complete QRS wave, which is built on my right so that you can see it again. Yeah, and then it starts from all over again. So you have the PQRST, most important thing for today. Let's go. So this is one of the patients whom I had at the emergency unit. I want you to look at the ECG. You see the limb leads, the augmented leads, and you see the chest leads, V1 to V6. Yeah. Now you have an ECG. The most important thing is when you look at an ECG and when you're trying to identify whether it is normal or not, you have to look at every complex starting from up there till down. So when you look at the QRS wave, or maybe so that there's no confusion, let's start at the P wave here. You have the baseline. You can see my arrow, hopefully. And then you have the P wave. The first question you ask yourself as a medic is this P wave, can I find it in most of the ECG leads? You scroll down with your eyes and you see you have a P wave. Is this normal? Yes or no? After the P wave, you have another baseline. You get the QRS complex. And now the question is, can I see the QRS complex in all of the leads? If not, it might be an artifact, or it might be something else which is not a good written ECG. So you may be you may end up wasting your time looking at an ECG which is an artifact. Then you have the baseline, the T wave. You look at the T waves again from up till down, and you follow them. And then you ask yourself, are all the T waves a positive amplitude or a negative amplitude? Are they going upwards or downwards? And then you ask yourself, is it normal or not? The most important thing you need to know now is the R wave, yeah, has to be positive in the same direction like the T wave. For example, you have here an R wave going up and the T wave is also up. So this is normal. But when you have the R wave going down and the T wave going down, this is what we call concordancy, which is fully normal. It means that both of them are concordant. But here on the third limb lead, you have a positive R and a negative T. You see it? It is not normal. It is not normal that they appear anterograde to one another. Okay, we'll proceed. We were not talking yet about what this ECG shows us. Then you have the baseline, and it starts afresh again. You have a P wave, QRS, T, P, QRS, T, P, QRS. And this is the way you look at the ECGs. Okay, most of the ECGs are printed with 50 millimeters per second. Sometimes you may have in your hand one which is written 25 millimeters per second. I will show you in the next course why this is important. But for now, all of our ECGs will have 50 millimeters per second. So is it a normal ECG or should I worry about the patient? The patient comes in with fever, around 68-year-old, blood tests, nothing special, troponin levels are negative, BNP levels are normal. Should I worry? Okay, if anyone wants to answer the question, just raise up your hand, you'll be chosen. Should I worry or not? You want to learn, we want to learn. Okay, in this case, I don't worry. Why? I will show you later on what happens to the heart when the heart builds scars. These are also signs of scars. If you have a negative T wave and a positive R wave, but it is only represented on one lead, then you can mostly say that it is a scar which has been built in the heart. The person has definitely an area of the lower chamber or the left ventricle has been affected or was affected maybe 5 or 10 years ago because of a coronary heart disease. It is not important for me right now because the patient doesn't have any chest pains, any symptoms, and we don't have high troponin levels, which indicate that the heart muscles or the heart cells are being distracted. Okay, so this is a normal ECG. The patient left the hospital doing fine. There was no need for coronary angiography. We go to the next ECG. Another patient of mine, you can see the ECG. If anyone would like to take us through it, you're most welcome. Is it a normal ECG or is it abnormal? That's the first question. And then you look at the P wave, the QRS waves, the T waves, and the baselines. And then you look at the leads. The leads, the V1 leads to the V6, they always indicate the electrical activity of the lower frontal anterior chambers of the heart. And the other leads, they mostly show us activities which happen on the lateral or the posterior chambers of the heart. So is it normal or is it abnormal? Anyone interested to help us out? It is okay if you say it wrong. It doesn't really matter. We are just learning. We are learning. Nobody. Okay. Okay. Okay, then let's look at it. If we see the P wave, it is a positive P wave represented on all of the leads. Even if it's a small P wave, it still exists. And then you have the QRS complex, which is also represented everywhere. And you have the T waves. You have an area where the T waves is a negative T wave, but you can see that it's concordant to the R wave, which is also a negative amplitude. And then all of the other waves are similar. They go up with the R wave. And then you'll ask me, oh, but you have said that they should be always concordant to the R wave. There is this exception, which we have mostly from V1 to V3. You always have a negative R wave. I will explain it to you later on why this is important. You talk about a shift from V3 to V4, where the electric impulses of the heart are being recorded. So this is also typically normal. When you talk about concordancy, we always talk about the limb leads and the augmented leads. So this is a normal ECG. Let's go to the next one. Or let's stay in this ECG for a while. When you are writing the report of an ECG, the first thing you have to write about, is it a sinus rhythm? For those who don't know what a sinus rhythm is, it means, is it a normal ECG with a normal heart frequency? That's a sinus rhythm. So is this ECG a sinus rhythm? Can we say that the R waves have the same distance from one another? In this case, yes. So we have a normal rhythm. Yeah, in this case, a sinus rhythm, because the R waves have the same distance from one another. And then the other question is, yeah, how do you measure the frequency of this ECG without having the ECG shown? You can see it on your right side. On the right side, there's a place written freq, that's the frequency. It is about 80 pulses per minute, which only means that the time which the heartbeat and the lower chamber needs to come back to another lower chamber heartbeat, the R interval makes up an 80 pulse per minute. So when you have a ruler or an ECG ruler which you use to measure it, you can just look at the R wave and you'll see that it is definitely 80, but you're talking about 50 millimeters per second. So now you have the PQ time, which is 163 milliseconds. We are talking about the P beginning from the P wave to beginning of the Q wave. There's a PQ time, which is 163. The normal time, the normal PQ time of an ECG is 200 and below 200 milliseconds. Every other PQ time, which is above 200 milliseconds, is most likely an AV block. We will talk about this later. Okay, and then you have the QT time. This is the time you need from beginning of Q to the beginning of the T. It is around 402 milliseconds. And then you have the QTC time, which is important for all psychiatric patients who are under citalopram or sertraline or all this stuff, or venlafaxine. You need to know the QTC time, yeah, which is always a bit higher for ladies as for men. And it shouldn't be above 500. We should agree at this for the first course, but there is a deeper way of looking at it. So it shouldn't be above 500 in order to avoid problems. The QRS time, yeah, it's a time which you need from here to there. It is a time which should be around under 100 milliseconds. When it is above 100 milliseconds or between 100 and 120 milliseconds, you should be considering a bundle block. But in this case, we will look at this later. Okay, so let's move to the next one. Any volunteers, come. There's nothing you can do wrong. There's nothing you can say wrong. Just put on your audio or just lift up your hand. Your audio will be put on, and so that we know what you think. Is this a normal ECG or is it an ECG which I should worry about? This is a 60-year-old patient who comes to the ER. Like I said, in Europe, it is normal. Every patient receives an ECG, whether they have chest pains or not. But patients who have chest pains have to be looked at. Is this a normal ECG or should I worry about it?
Daktari,
Yeah.
I think there's somebody else raised a hand. I think Karim can.
Yeah,
let me unmute them first.
Okay.
Okay, Karim, you can unmute yourself.
Well, I see in number 3, PQ. R is up and T is down.
Okay. Yeah,
So
definitely.
They're not in phase, like,
Yes.
So,
Then.
So there's a problem over there.
There's a problem over there. Okay. Do you see any other place where there's a problem?
Again, in V2, but V2 is, I mean, we haven't got much into that. V2 also, I see there's a T which is going up, and the PQR, which is going down. They're not in phase. Yeah.
Okay. So there's definitely.
Two.
What do you think? What do you think about AVF? Look at the AVF.
AVF. Yeah, I see that AVF. Yeah, that thing is flat. Yeah, T is flat.
Okay,
But
we have a flat T, almost a negative T. We have like 0.01 millivolts. So it is also negative. So it is definitely not a normal ECG.
Yeah.
But the patient doesn't have any symptoms. What do we do next?
Well, I'm not a doctor, but you'll know.
Yeah, just guess. What would you do if you were a doctor?
It's something to look more deeply, but he doesn't have pain, you told me.
Okay. So if you're a nurse or a radiographer, you'll show this to a doctor and the doctor will look at it and say, okay, yeah, noted. Yeah. Okay. This also looks definitely like a scar. The patient doesn't have any problems. So I have a question for you, sir. Is it a sinus rhythm? We have a regular heartbeat.
When you look at the top, it looks like a sinus rhythm. P is there, QRST is there. Looks normal. Looks normal from limb number 1. Yeah,
that's true. You're right. It's a sinus rhythm. And the heart frequency, is it something we should worry about?
It's 69. Yeah, it's normal. Looks like normal.
It's normal. Okay.
Yeah.
What about now? I'm just asking a special question, but we're learning. Yeah. What about the PQ time? 137 milliseconds.
PQ. Well, I haven't sort of go deep into that, but it has broadened a lot. It's a bit broad, not totally narrow, but I don't know really. I'm not sure.
So it is normal because it has to be below 200 milliseconds. Yeah. Okay. But thank you for helping us. So we'll go to the next ECG. So whoever wants to can look at the next. These is a normal ECG. We have in the third limb lead and in the AVF we have a negative T complex, which may be a scar, which happened during a heart attack somewhere, someday. If you see such a change where the S is missing or even rising up, but you see that we have the same baseline, and that's the most important thing you should look at, that the baseline from this part to that part is the same. So we are not talking about an ST elevation, but we're talking about a missing S wave. A missing S wave can be a scar, and you can see also here we have a negative T wave. It will be a scar somewhere in the left ventricular heart, but we will look at it deeply on another side. The most important thing is that the patient doesn't have symptoms. You have a normal frequency, you have a sinus rhythm, and you have to look at the blood test. That's the next step you do. It may be a lateral infarction. So you do troponin levels, you do CK levels, creatinine kinase, and troponin T or I. And then you look at the levels. If they are normal, there's nothing to worry about. The next step is an echocardiography. You look at whether the muscles of the heart have any regional disturbances. And if not, everything is well. The patient can be checked by a cardiologist twice a year. Our next ECG. Now, this is a patient. He was 47. He is 47 years old. I met him on Saturday. He actually came with other symptoms. He had pain, abdominal pain, and he came to the hospital because of a gastritis. And yeah, we were looking at him, and then we saw this ECG. We didn't expect to do the ECG, but like I said, it is normal abroad that every patient who gets admitted receives an ECG. So we do the ECG and we are surprised, like, oh, what is this? Okay, is it a normal ECG? Anyone willing to talk to me about this ECG? Just turn on your microphones and let's go, let's go. We are learning. You won't learn if I tell you everything. You learn if you also...
Shall I say something?
Yes, yes.
There are some P waves missing. And,
okay.
The rhythm, there is arrhythmia as well.
Mm-hmm.
There are short gaps and long gaps. So there's arrhythmia, there are P waves missing.
Mm-hmm.
So, yeah, the heart is not operating properly.
Okay. Okay. What do you mean by not operating properly?
The ventricular side,
mm-hmm.
the atrial side is not contracting.
The ventricular or the atrial side?
Atrial.
Atrium. Yeah. Remember the picture I showed at first, the PQ time is the atrium time. So the atrium, that something is not happening well there. So yeah. What do we talk about when you look at this ECG? Well, I see some other P waves here. Someone will argue and say, but I see P waves there, they're lying. Look at this. They're an AVL. Someone may say we are lying because there are P waves over there. What do you think about that?
It's a bit negative though.
Okay, just look at all of the waves, all of the leads, and tell me whether this P wave, this small P wave can be seen everywhere. Definitely not. Yeah. Okay, someone has turned off. Just feel free to turn off your microphone. Okay, so we have an irregular heartbeat. P waves are missing. We don't have any ST elevations. What do we call this? You don't learn by listening to me. Just turn on your microphone. Tell me, what is this? Sorry?
Atrial fibrillation.
Yes, it's an atrial fibrillation. Should I worry about it? The patient is 47.
Yes.
Okay. What will you do next?
Possibly an echo. And
okay.
The troponin T and CKMB.
Why would you do a troponin T in this case? I know I'm just asking. I'm interested. You can't say anything wrong. What are you looking for when you do troponin T? Yeah, we're looking for
cardiac ischemia. It denotes cardiac ischemia.
Sorry?
It denotes cardiac ischemia.
Ischemia?
It denotes cardiac ischemia.
Okay. But it's an arrhythmia. We're talking about an arrhythmia in the atrium. Does troponin T tell me anything about atrium contractions? Or is it more specified for the lower chambers where we have a lot of muscles and cells?
Yes, you're right. It's more more concentrated on the lower chambers.
Okay, so troponin T wouldn't help me really. Yeah.
Correct.
Is the pulse normal? Is the heart frequency normal by looking at it? I think I have the I know. Sorry, is the heartbeat normal? Is it fast or slow or a normal heartbeat?
It changes.
Okay, we have here a lower heartbeat and here a faster heartbeat. So the first thing I look at it, I look at it, I know it's an atrial fibrillation. What consequence does it have for a 47-year-old?
Thromboembolic event such as a stroke.
Okay. Are you a doctor?
It's, well, final student. I've just finished. So
okay. So according to the guidelines, there's a thing called the Chadva score. Yeah, that means you look at the age. Embolic events take place around 65 to 74 years of age. The other thing you need to know about this patient is what? Apart from the age. So the age doesn't really matter for us. He's not yet 65. The other thing is whether he has blood pressure medication, which gives him 1 point. From 2 points of a Chadva score, you'll have to give the patient an anticoagulant. Yeah, until then, you'll have to just follow up the patient. He has to know that he has an atrial fibrillation. And by the time he gets 65 or takes more than 2 medications, he'll definitely be anticoagulated. So you need to know the age. You need to know whether the patient has any vascular issues in the past, whether the patient has blood pressure, heart congestion failure. You need to know whether the patient is a male or female, because every female gets 1 point. And then you also need to know whether he has had heart attacks or strokes in the past. Yeah. So look at it in a calm moment. It's called the Chadva score. Yeah. The Chadva score is what you use in order to analyze whether this is a patient by which I have to react immediately, or just a patient who we know, atrial fibrillation, regular checkups through a cardiologist or a cardiac physician, and that's all. Okay. So there is a patient who will most probably get a stroke, when he's 70 and has no anticoagulants. Or some of them even at around an age of 50, if you have obesity, blood pressure, and diabetes. So all of this stuff has to be looked at it. The patient was, he didn't have any medication, and he was also not sick in the past. He doesn't have a sick past. So that's why we did not do anything, but we noted it, and he has to go for regular checkups. Let's go to the next ECG. Is this normal or not normal? We have to move a bit fast due to time. Someone just sacrifice yourself. Also, a patient, you can see the date, 11th February, a patient who I saw at around 11 in the morning. Is it normal or not normal? Anyone, come on.
This is like a sign of atrial fibrillation, definitely, right? Those oscillations between T and P. That's atrial fibrillation.
Okay, let us always try not to get a diagnosis, but to just read the ECG first. Do we have normal P waves?
No. No.
No normal P waves, even here?
I see them.
From up to down, so we have the P waves. You see, now you made a diagnosis, but now we have to read the ECG first. So the P waves are there. Is it regular or irregular? When you talk about regularity, you talk about the distance between two R waves. Are they regular or irregular?
the P wave on the last part doesn't show, right? At the end.
This one?
Yeah, at the top.
Yeah, it's flat, but it's
Yes.
important to look at all of the leads. Yeah, just most of them have to have a P wave. This is because the ECG was not placed really well. That's why you can see the P waves, but you have here at the same second, you have P waves here and here. It's a tricky ECG, I know. It's not a typical one, which was expected. But is it regular? Atrial fibrillation is made of missing P waves and irregular heartbeats. That's the definition of atrial fibrillation.
Okay. Well, the heartbeats look regular.
Okay, so it's most probably not an atrial fibrillation. Actually, this ECG, I got it from a surgeon. This is a hip fracture. The guy had a hip fracture and the surgeon wanted to, he was not worried about the irregularity. He was worried about the heart frequency. Look at the heart frequency and tell me, should we also worry?
It's bradycardia.
Yeah, it's bradycardia now. You see, it's an irregular heartbeat. You have P waves. It's a sinus rhythm, but it's a bradycardia. So we talk about sinus bradycardia. Look at the PQ time, 203 seconds. Should we say it's normal or abnormal?
Just above.
Yeah, it's just above.
Yes.
So when you see a sinus rhythm with an length PQ time, you talk about an AV block, first grade. Okay, so we're looking at a sinus bradycardia with an AV block of the first grade between 200 and 400 milliseconds of PQ time. You have the definition, I'll tell it again. Atrial fibrillation is defined by missing P waves in all of the leads and irregular heartbeats. While AV block, for the first grade, AV block is defined by a sinus rhythm, but the time between the P and the Q electrical activity is higher than 200 milliseconds. So you talk about an AV block first grade. Okay, let's move to the next ECG. Now it's getting more interesting. Or let us skip this one because this one is very complicated. We'll get back to it. Let us go to let us go to this one because you're already talking about. Where's the sir who helped me again? Who said the sinus bradycardia? What do you think? There is a patient from my own practice the day before yesterday. She had bronchitis last week, received antibiotics, comes back with dyspnea, and actually she doesn't have any infection. And now we were wondering, okay, how can she have dyspnea, although the bronchitis was treated? So we measure the saturation levels, the blood pressure, we measure the pulse, and we find out, whoops, she has a pulse of 153. And then this is the ECG, which was written after taking some measurements. What do you think? And let us stick on the plan. Look at the P waves, the Q waves, the regularity. Is it a sinus rhythm? And then we can talk about the diagnosis. Anyone ready for this?
This is a difficult one.
It's not really difficult. Just go step by step. Start with the P waves. Do we have P waves?
P waves. I know some of them there are.
Whoa.
It lead to the second wave.
Second lead, where?
Yeah. at the beginning, second wave. Yeah, there. Just go to the right. Go to the right. Right there. Yeah, there. Is that a
This
P
one.
wave?
Is
Yeah,
it
what
a
is it?
P wave or a T wave?
Oh, it can be a T wave from the earlier one.
Yeah, but then look at it from, always look from up till downwards. Look at it now. What could it most probably be? It's most probably,
Yeah, T, yeah.
it's a T wave. So we are missing on P waves. Is the heartbeat regular?
It's irregular.
It's irregular. So what's the definition? Per definition.
No P waves, irregular. It's a fibrillation, yeah, atrial fibrillation.
It's an atrial fibrillation. Okay. Okay, but we're not finished yet. We have a problem. Look at the heart frequency on the upper left side.
It's 138. Tachycardia. Is it 130? There's the
No, it's
pressure.
167.
Yeah, tachycardia.
Yeah, here, 167. So it's a tachycardia, but it's not a rhythmic tachycardia. So we're talking about a tachyarrhythmia absoluta. Yeah, an absolute tachyarrhythmia. Yeah, that's what you call it, definitely. Okay, should I worry about the patient? Shortness of breath. The blood pressure is here indicated on the right upper side, 138 to 89. What will you do? Let's say you have the patient in your emergency unit. What do you do with the patient?
That's the doctor's job.
You should say, Daktari, yes. Is there any doctors here? Come. Some of the medical students or the doctors, speak out. What do we do with the patient? Okay, before you leave me, look at the T wave here at V4 to V6. Is this normal? Look at them. And even here in 1, is this normal for T waves?
We should not go negative, yeah?
Yes. So we have a negative T wave in V4 to V6. And even here in 2. Okay. So we definitely have, yeah, somewhere we have an ischemic thing coming out. So the fast heartbeat may be the cause of shortage of oxygen for the left ventriculars. It may be that when you help the patient, that the T waves will disappear and become positive again, but they may remain, which makes us think about a heart attack, a late stage heart attack. Yeah. Okay. So some of the doctors on the ground or the medical students, come on now. What do we do with this patient? Send them home, give them fluids.
Perhaps again, you can anticoagulate and also give a beta blockers.
Okay, beta blockers.
And also for anticoagulants.
Okay, the patient is 78 years old. Has a hypertonic problem, no diabetes. Why would you choose an anticoagulant? And she's a female. Okay, we want to help the patient at first. You say B blocks. Okay, which beta blockers would you use at this case? Would you do an IV beta block, or would you give them, yeah, tablets? You can't say anything wrong. We are learning. We're learning.
I would say intravenous because she's in the hospital. And it's something is like emergency, I think I would say. Something should be.
Yeah, the patient has to, is this a patient for a normal ward? Is it a stable patient or an unstable cardiac patient?
It's not stable, I would say.
Yeah, she's not stable. Yeah, we have,
So she needed Immediate treatment. So intravenous would be the right thing, I would say.
Yeah, so we have to intervene intravenously. Yeah, metoprolol or Belloc, yeah, is the one which you have in IV. You can give it to the patient, give the patient metoprolol 5 mgs, and the pulse only goes up to 160. Even after giving the patient 5 milligrams or even 8 milligrams metoprolol IV, the pulse is not sinking. What do you do? I'm looking at the time. Okay, the patient has dyspnea. We have to have the patient fast. The patient needs intermediate care. That's the first thing you do. They have to go to the intermediate care unit, and under monitoring, what you can do for the fast is think about giving metoprolol for a long period of time as an infusion. What you can also do is give amiodarone, yeah, in order to see whether you can convert this out of rhythmic failure to a sinus rhythm. The problem is, if this patient has the issues or the problems longer than 24 hours, you could end up giving the patient a stroke by treating them with amiodarone or even electrocardioversion. Yeah, that's actually the therapy which you need, an electrocardioversion. But before you do it, you will need to make sure that there are no embolic stuff in the atrium heart ear. So the first thing is, yeah, IMC. Try doing it to the highest beta blocker you have, 5 to 10 mgs bisoprolol or up to 100 mgs metoprolol. See whether the patient is reacting. If not, you will have to do a transesophageal echocardiography, yeah, to make sure there's no embolus in the heart. And then afterwards, you shock the patients with electrocardioversion, yeah. And then you send the patient home with anticoagulants because of the high chart vascular, female diabetes, blood pressure, yeah. You have a 0.3 point patient, definitely they will need it for the rest of their lives. Otherwise, they will shoot a stroke and will have a problem. Okay. So I would like to move forward. I'll just skip them due to time. What you see here is a left bundle block, ventricular extrasystole. This is something we'll discuss next time. I want to move to myocardial infarction for the next 8 minutes, and then we finish and we open up the questionnaire round. When you talk about myocardial infarction, heart attacks, remember, we're doing this course today, but we have to repeat these things over and over again until they're really, yeah, seated in your minds and in your hearts. So only one course will not be enough. Remember to register for the next course, yeah, and always to repeat it and repeat. If you have ECGs which are unclear, send it to me so that we look at it together. Okay, you have 4 phases, actually 5. You have the first phase, this is the early phase, where you have a QRS wave, but here you have a high positive T, which is starting to come out from the heart attack which the patient is experiencing. It is very rare to see phase 0. I haven't seen it myself. It's very rare, but if you are an emergency doctor, you're called to a patient, if you see the patient collapsing and you do the ECG immediately, you may end up seeing this phase. Mostly what we see is a phase 1, where you have an ST elevation. That means the baseline is here, and you have an ST elevation. Sorry?
Sorry.
Yeah, so you have a monophasic ST elevation, the T is positive, you're already seeing a heart attack. This patient is a patient who needs to be intervened on immediately. There's no time to waste. So, because the ST elevations are the most deadly ones. Most of the patients who have it, they will die within the next 6 hours. So if we waste time, you may end up losing the patient. So I know in Kisumu, we don't have a heart catheter lab, but in Nairobi, you'll have to fly off the patients if they're stable enough. I don't know, we'll have to figure out a solution for that. But in phase 2, you see a small, smooth ST elevation, which is regressing. But then you also have a negative T. And the longer you wait, the more it changes. If you're lucky, it changes, and the heart becomes to resemble itself. And you have only a T wave, which is looking down. The baseline is still there. But you still speak of an ST elevation because normally the S would have gone down like that and up again, but we still are missing the S wave. And then phase 4, if we are lucky, we only have something like this, but most of the patients die at this phase. When you meet a patient who has chest pains, you do the ECG and they have a negative T. That means you have like 48 hours to intervene. They may be lucky and the heart may regenerate themselves so that they don't die. But most of the patients, if we do not act early enough, will end up losing them. After having heart catheter, you may also have patients who still have T waves which are negative or which are peaked, and which is done, as we saw earlier, we just say it's normal and there's nothing you have to do about it. Well, I had a patient like that who came with back pains. Now you see an ECG, normal heart frequency, PQ wave is okay. You have the P waves, the QRS waves. And then when you look at the T waves, you see a negative T in 2 and 3, AVF, V5 and V6. And also what you see, what most people miss, is a missing S wave. So I go back. We are seeing the patient is practically at this stage, phase 3, and look at it again. Yeah, the patient is at phase 3. So we have definitely a problem here. I did the troponin levels, CK levels. Troponin levels are very high, yeah, above 1,400. And the patient himself, apart from the back pains, he didn't have anything. So this is a patient, we talk about an N-STEMI because we don't have a classical ST elevation, but you have a late progression of the T wave. And we are missing also the S wave, which is normally here. So we are around phase 2 or phase 3, a patient with a heart attack. Okay, so we will also have another ECG course in the next 5 weeks. You can send your printouts or outprints, whatever you have, on this number per WhatsApp, and you can look at it. For me, it's important, if you have not followed yet, follow on Facebook, on Instagram, on Twitter, or anywhere you see us. Our organization is called Dokis Advice. We come twice in a year to Kenya and treat and help, but it's also important for me to empower you guys with knowledge. If you're interested, I would like to, for those who have time, I would like to look at 2 ECGs which show us a myocardial infarction, and I would like to have like 2 people who just will help us understand whether it's really a myocardial infarction or not. And then I'll proceed to the questionnaire. Is it okay? So let's go. 2 people, volunteers. I'll just do this. I'll show you one. Okay, one. Okay, do you see it? Let me move this. The patient on a monitor Anyone? No one? Any volunteers? Is it a normal ECG? Is it abnormal? Okay, here you have everything you need. Someone, please. No one. Okay. Okay, any volunteer who doesn't know what it is but would like to join me in this journey of interpreting this ECG?
Are they able to unmute? And also, if they can use the reaction button to raise hands.
Use the reaction button to raise hands, please.
Yes.
42-year-old patients with chest pains. The P waves, the QRS waves, the T waves. Yes, I think, Karim, you can just turn on your.
Well, I'm not experienced, but I see the P waves are there.
Yes.
The P waves are there, T waves are there. But how come this QRS waves, like they're equal size, S and R, something which I'm not sure about.
Yeah, okay.
They look like equal, but otherwise the P waves are there.
Okay, let's look at it systematically. We have the P waves.
Yeah.
Okay, the QRS, they're a bit long here, you're right now. Yeah, mostly when you look at such R waves which are very long, it may be a hypertrophic heart disease, yeah, or a blood pressure patient. But this, yeah, this is okay. What about the S? When you look at the S, is it elevated or is it normal? Or
S is like a long, it has gone more negative.
yeah, if you look at the baseline, let's look from here.
Yeah.
The baseline is negative, and then here, you look at the baseline, it's elevated a bit. Here, it's missing.
Yeah.
Here it's normal, and then here it goes up. So you have the baseline, and you have a small elevation here. Okay, and the S goes down. Okay, what about the T wave?
T is there at the beginning.
At the beginning, it's okay.
And it gets inverted at the bottom.
Yeah. Here, augmented limb, it's inverted, and here also V1 to V3. So we have an ST elevation. We have an S which is missing in some of the leads, and we have a negative T. Are we in phase 1, 2, 3, or 4? What would you say? Just guess.
Look at the diagram again.
Yeah, let me get the diagram. How can I get the diagram without losing you guys? Okay, you see the diagram.
Yeah.
Okay.
Yeah, between 2 and 3, yeah, phase 2 and 3.
Yeah, between phase 2 and 3. So is this an emergency?
It is.
It is an emergency, yeah. We have an ST. This patient, if not treated quick, will end up losing the patient, yeah. They'll die, especially if they have chest pains. Yeah, and if this ECG was done too late, then it's also a matter of time. The heart muscles have been, yeah, they're all distracted and destroyed. Yeah, so we have an ST elevation. This is a typical heart attack, and what you see here, it looks like an artifact. It may be an artifact, but it also could be a left bundle block or a ventricular extrasystole, but we'll have to look at it later. Now, this is something special. So is it regular?
Bit irregular.
Okay, it's the most part of the ECG is regular, and then we have an irregular part here, which makes us think about a ventricular extrasystole. Yeah, this is just an extra heartbeat because of the scars which are appearing at the left ventricular heart. Okay, I'll choose another one for you guys, and then we will go to the questionnaire. Let me choose another one. Okay, and another one, maybe something much easier. Okay. Okay, I'll just get one for you guys and then. Okay, male, 65 years old. And you have it. Okay, it's a bit strange like that. I'll just make it. I'll just draw it for you. Okay. Anyone? What do we see? No one? Just raise your hand or turn on your microphone.
There are places where P are missing, and there's some places where P are there. I think I noticed.
Yeah, definitely.
What about T? There are inverted T's, some places.
Yeah. Is it regular?
Slightly irregular.
It's irregular, but we have P's. So we will talk about a sinus arrhythmia.
Yeah.
So it's a normal arrhythmia which can occur in some young patients who mostly have sinus arrhythmias. They are mostly, some people, they call it an atrial fibrillation, but it's not an atrial fibrillation because we have P waves everywhere. Yeah, even though it is irregular. So we talk about a sinus arrhythmia. What about the ST region? Is there, okay, let us, the T waves here, they're negative. You said they're negative in some regions, AVL and in one. What about here?
The ST is elevated, isn't it?
The ST is definitely elevated. Yeah, we have a ventricular escape rhythm. Yeah.
So it's a heart attack, is it?
Yeah, it looks like an extensive anterior wall acute myocardial infarction. This is also a patient who doesn't have any time to lose. Yeah. This is an emergency. Yeah. Especially when the blood pressure is low and when they're tachyarrhythmic or bradyarrhythmic, like this one looks like 52 per minute. This could also be very dangerous. So just before we finish, what do you do with such a patient, Karim? What do you think? What would be the next step?
Straight to emergency.
Yeah, straight to emergency sector or to ICU if you have an ICU.
Yeah.
Yeah. And then?
The doctors.
Okay, the doctors now. The doctors, where are you?
Sorry?
The medical students, the doctors, I expect more from you guys. Come on. What do we do now? Which medication do we choose? Patient with chest pain, 64 years old. You have to do an ECG within 10 minutes. We have done it. We have an ST elevation. We are shocked. And we are somewhere in Western Kenya where the roads are bad. And we have sent the patient to the next ICU hospital. Yeah. And now you are the doctor. You have taken over. What's the next step? Just unmute yourself and go ahead. We want to go to the questionnaire time. Madaktari, Mashuja.
So in the chat box. Okay, let's go ahead. Go ahead, Stanley.
Double anticoagulants, maybe aspirin, clopidogrel, oxygen, morphine, for the pain management, lifelong statins, and possibly a beta blocker or an SI.
You said a beta blocker?
But you told me the rate is low, so
yeah, that was the case.
Yes.
Why did you choose clopidogrel and not aspirin?
I would choose both, but just
yeah.
Yes, I will choose both of them.
You will choose both of them. So you'll give the patient 600 mgs clopidogrel and aspirin. How much? IV or oral?
IV.
Yeah, good. Every patient who is unstable like this one, there's no time to waste. Now you have to do it IV. So how much IV do you give? How much mgs? Do you know the dose? I'll give you ABC, 100, 250, or 500.
500.
You give it all, yeah? Okay, until 5 years ago, the guidelines used to say 500 aspirin, 500 mg aspirin IV. Nowadays, it's 250 mg, but you'll still find other doctors doing 500, which is not wrong. The guidelines say you have to do aspirin, morphium if they have chest pain, and you have to give them heparin. How much heparin would you give IV? Okay, I'll give you another guesswork now. 500, 10,000, 20,000 units. How much would you give them? Amepotea. Okay, nobody. It's a guesswork. 500, 5,000. Okay, yeah.
5,000.
You're right. Okay, I will. Before when we used to study, we had a bridge called as something like a bridge system which we used to learn things off it. 500 aspirin, 5,000 heparin. Yeah, you just look at the 5. So when you come in such a situation, just know 500, 5,000. Yeah, there's no 5,000 aspirin, so you won't get it anywhere. So you have 500 aspirin and 5,000 heparin. And the patient has to be in a catheter lab within the next 2 to 4 hours. Yeah, for revascularization. Otherwise, we lose heart muscles. So if you don't have the possibility, like in Kisumu, yeah, you don't have the possibility to do a coronary angiography, what do you do with the patient? He's on the ICU, you have given the loading dose, aspirin, heparin, you have thought about clopidogrel or ticagrelor, whatever you choose. What next? Is there any other diagnostics which you can do? What would be the next step? Just unmute yourself and speak. Yeah, you definitely, Mohammed Sharif is saying, I'll do an echo. You need an echo. What are you looking for in an echo? About the thing with streptokinase, the problem is if you do an ATP or streptokinase by this patient, you may end up producing a cardiac tamponade through bleeding because the scars will open up and the patient will end up bleeding. That's why I wouldn't do it in such a case unless you have no other option, and it's do it or lose it, and then you really have no other option, then you can do it. But in that case, that won't bring anything much. What you can do is a heparin perfuser for 24 hours or for 48 hours in an ICU setting, stabilize the blood pressure, stabilize the pulse, and then wait and watch. Yeah. If you do an echo, what are you looking for? A WMA? Where? In the anterior and the posterior walls, in the lateral walls. Okay. Yeah. This looks like an anterior wall acute myocardial infarction. So we'll definitely have to look at it there. No? Yeah, okay. Yeah. Okay, so do you want to do questionnaires or do we want to have more ECGs and then we close? If there are any questions from this point, now is the time. Otherwise, I will say whoever has to go, thank you for being with us. Thank you for watching. Be there next time. We'll learn more. We have just done, I can show you what we have done. We have done only 5% of what we should be doing. We have done atrial fibrillation and sinus arrhythmia. All of this stuff, we haven't done them yet. Yeah, and we also haven't done this yet. And we haven't also seen enough ischemia or infarctions. Yeah, so there's still a lot to learn. What do you prefer, guys? More ECGs? I still have 20 minutes, or we leave it for today. Any questions? Okay, people are texting more ECGs. Okay, then I look for one. Today we have seen two types of important diseases, atrial fibrillation and myocardial infarction. So I'll just go on and see whether you can see whether any ECG is the same or not. Okay, let's go to the next one. Okay. Okay, what do we see? This is a bit difficult now, but it's also something we have already dealt with today. Anyone, radiographers, come on. The medical students, yes, speak. Someone, you want to save time, you want to see more ECGs, you'll have to interact with me. I'll wait forever. I'll drink my water and wait for you guys.
Those look like T waves and not P waves.
Mm-hmm.
The rhythm is irregular.
Yeah, the rhythm is irregular.
I see the oscillation between T and P waves, lots of oscillations.
Mm-hmm.
Lead.
Yeah.
Could that be atrial fibrillation?
Yes, it is atrial fibrillation, but there's something else you're not seeing. It is atrial fibrillation, you're right. Irregular, no P waves. But look at V1, what is that? Have you ever seen this before?
V1. There's an inverted T, isn't it? There's an inverted T.
Yeah, something is happening there now. Have you ever heard of a sawtooth pattern?
I'm not that qualified, but yeah.
Yeah, like it looks like a sawtooth. Now look at especially this region. Looks like a sawtooth. Yeah. Typical for V1 and V2, when you have another form of atrial tachyarrhythmia, there are only two types. You have the fibrillation and flutter. Yeah. So if you check whether someone already put it in, sawtooth, a flutter on V2. Yeah, so we have atrial flutter. Now these are typical atrial flutter. Yeah. Treatment is the same. Yeah, you can, in this case, you have a pulse which is ranging from 40 to 124. So you can try beta blockers. If it doesn't work, you can give adenosine to just differentiate it, but actually the diagnosis is clear. What you need to do is cardiovert. Yeah, that's all what you need to do. So do a TE before and then do an electric cardioversion. Okay, let me get another one for you guys. Okay. Somebody speak. I just drink my water and enjoy. Remember, we're not looking for diagnosis. We want to interpret that thing. Look at the P waves, the QRS waves, the T waves. regular, irregular, fast, slow. You guys want to check the chart, no? What is happening? Okay. Someone's talking about an elevation. It's an abnormal ECG. Okay. Regular or irregular? Okay, no one willing. Okay, I'll just proceed to the next one. It's most likely another atrial fibrillation, yeah? But a very fast one, yeah, which needs to be checked out immediately. And also we have a right atrial expansion. The ST region may be tricky. The problem is when you have an atrial fibrillation in a tachyarrhythmia, you cannot really to 100% read the ST time or the ST wave. Yeah, the P waves are missing, it's irregular, so we are talking about an atrial fibrillation, and the ST section, we can decide about it after reducing the pulse and the heartbeat a bit. Okay. Okay, now something different. Okay, so you get one more. Okay, what is this? Someone, anyone? We only have 2 minutes. Where's Karim? Karim used to help me a lot. Karim, come on. Everyone is afraid. No.
I see the P waves over there. And the T waves get inverted at the bottom.
Yeah.
But I really don't know how to weigh what is right, the upper part or the bottom part.
Yeah, that's a big question, yeah.
Yeah.
Is it regular or irregular?
Looks very regular.
Yeah.
Looks regular, yeah. Looks regular.
Okay.
The T waves are inverted at the bottom.
From which leads 1, 2, 3 every or
V1, V2.
only V1 and V2?
V2 and V3 as well?
Yes, V1, V2, and V3, they're reverted now, reverted T waves.
Yeah.
The patient comes with, it's a 63-year-old patient. 1 week ago, she kind of had a cough and a small stitch on the left side, which disappeared after 2 to 3 hours. She didn't think that it's something serious. Now she's coming a week later to consult a doctor and tells you about this. You do the ECG, and this is what you see. You have the figures down there. Yeah, the QRS time, PR time. Yeah, everything is written down there. What do you do next? Is it a stable or an unstable patient?
The rhythm looks stable.
Mm-hmm.
It's just the bottom part which is concerning. Does he have chest pain at the moment?
Mm-hmm. Yeah, she had chest pains before, like
Before,
a week ago, and sometimes, 2 or 3 days before, also in the night, she had some chest pains, but they disappear from
so it is
like that subsequently. Yeah.
Well, she looks stable at the moment, but why the chest pain? Why the chest pain?
Mm-hmm.
Further investigation advised.
Okay. If you had a laboratorium nearby, what would you look for?
Angiography?
No, lab tests. If you could do lab tests. Mm-hmm.
What is that called? Troponin test, whatever?
Yeah, troponin T and troponin I, or CK. Okay, you do the troponin. They're not so elevated as they normally are, but they're also not in the normal region. They're not normal levels, but also not so too elevated.
Would a stress test be advisable to know whether the stress test?
A stress test, echocardiography stress test.
Yeah, stress test.
Okay.
Just to see we haven't come to that topic yet, but the ST elevation, the depression, whether it goes with a stress.
Okay. Are we what are we worried about?
I'm worried about the blockages.
Mm-hmm. Okay.
So how do we definitely find out the blockages?
Okay. V1 to V3 speaks about the anterior parts of the heart. Will you still do a stress? Let us do maybe a normal echocardiography, just a normal one.
Okay.
Yeah, we do a normal one.
Yeah.
And then we have a hypokinetic septum region. Yeah. And the left ventricular volume is around 45%. Ejection fraction around 45%. You're just learning, Karen. There's nothing wrong we can do.
Thing is, I'm not in the medical field. It's just my interest which has drawn me over here.
Ah, okay. So in which field are you actually?
Sorry, I'm an electronic engineer.
Ah, yeah, man, you're crazy. And now you're sitting in an ECG course and teaching the doctors and the nurses who don't want to speak.
It's just interesting, very interesting.
Okay, so we definitely have a problem here. We are talking about an N-STEMI, and non-ST elevation myocardial infarction. We have high troponin levels, and we also have negative T's in the arterial region. The ejection fraction also speaks about a disbalance in Sauerstoff in oxygen levels of the heart. So this patient definitely needs a coronary angiography, but she's stable, doesn't have to definitely go to the ICU. If she has chest pains, we may have to put her at the IMC intermediate care and wait and see what happens next. If they don't have the money for a coronary angiography, then we will choose to give aspirin, 5,000 heparin, and also maybe clopidogrel for 1 year. And that's all, definitely. Okay, so our time is up. I hope you enjoyed the session. We will definitely talk about more ECGs the next time. I will invite my colleague to talk with us for the next session and give us some ECGs of his own. And I'm also excited to be a part of it. So see you next time. Remember, wait before you close. Very important. Yeah, we need more followers on our site. Remember to click on that follow button and remember to save the date, 22nd of March, 2023. See you then, guys. Have a nice evening.
Thank you.
Yeah, anyone who has pending questions, we should have 5 minutes. You can stay around. Otherwise, bye-bye and a nice evening. Thank you, Karim. You're the best.
Thank you very much.
Yeah.
Would you have follow-up notes for this?
I can send you something else. Yeah, just write them as email and then I'll see what I can do. I can send you some of the ECGs and notes.
Yeah, thank you very much.
Okay.
Thanks.
Thank you very much. It was great. Really enjoyed that.
Yeah, welcome.
Thank you.
Thank you, Dr.
Karibu sana.
Nice. So I'm going to close. We have it recorded. I think I'm going to share.
Okay. Yeah,
Yes.
definitely. Okay. What did we have? Did you have anyone on the phone or?